Hi everyone, and welcome to the Clinics Review Articles podcast series. I'm Taylor Hayes, the managing editor for Endocrinology and Metabolism Clinics here at Elsevier. Endocrinology and Metabolism Clinics is a quarterly publication consisting of review articles focused on a central topic related to obesity, diabetes, thyroid disease, bone disorders, reproduction, hypertension, and much more. Today, we will be discussing the September 2024 issue, which is an update to the 2011 issue on endocrine disorders during pregnancy, guest edited by Drs. Rachel Pesapolek and Maria Papalyonto. Dr. Rachel Pesapolek is a clinical professor of medicine at NYU Grossman School of Medicine and specializes in thyroid and metabolic bone disease. She is the current co-chair of the International Society for Clinical Densitometry's annual meeting and recently completed 2 terms as a board member on the National Board of Directors for the American Association of Clinical Endocrinologists. Dr. Pesapolek graduated from SUNY Upstate Medical School. She completed her residency in internal medicine at the Icahn School of Medicine at Mount Sinai and her fellowship in endocrinology, diabetes, and metabolism at Mount Sinai Hospital in New York City. Dr. Maria Papalyonto is an associate professor of internal medicine in the Division of Metabolism, Endocrinology, and Diabetes. She's also a research associate professor in the Institute of Gerontology at the University of Michigan. She's a nationally recognized expert in thyroid disease with a repertoire of more than 50 peer-reviewed publications in the field. She is a recipient of the ATA's Women Advancing Thyroid Research Award, the Young Physician Science Award from the American Society of Clinical Investigation, and the Rising Star in Endocrinology Award from the AACE. Lastly, she's an associate editor for Endocrine Practice and on the editorial boards for thyroid and BMC endocrine disorders. Now let's hear from our guest editors to learn more about this issue.
Hi, I'm Rachel Pesapolek, and this is Maria Papalyonto, and we are your co-editors of the Update on Endocrine Disorders During Pregnancy edition, just published by Elsevier.
We asked our authors to share some clinical pearls, some of their favorites, in a short podcast. We are really excited to bring to you a variety of important and novel chapters regarding pregnancy, including thyroid disease, bone health, hyperlipidemia, congenital adrenal hyperplasia, and many, many more.
Now let's hear from some of our authors. The first chapter that we'll discuss is titled Diagnosis and Treatment of Hyperglycemia in Pregnancy, Type 2 Diabetes and Gestational Diabetes, written by Dr. Aoife Egan.
Hello, my name is Aoife Egan and I'm an associate professor in the Division of Endocrinology at Mayo Clinic, and I wrote this paper with my colleague Dr. Sneha Mohan, who is a senior fellow in our division. This article provides an overview of the diagnosis and treatment of gestational diabetes and type 2 diabetes in pregnancy. These are the most common metabolic disorders affecting pregnancy and are very important both during the pregnancy and also in relation to women's health in the long term. In this paper, we highlight the appropriate testing to identify undiagnosed diabetes in early pregnancy and the currently accepted screening and diagnostic tests for GDM. We then move on to a discussion on the management of diabetes during pregnancy itself. We highlight the key point that pre-pregnancy care is essential for all women with established diabetes and can be delivered by a multidisciplinary team. Pre-pregnancy care includes a discussion on pregnancy planning, optimization of A1C, and we emphasise that a periconception A1C of less than 6.5% is associated with the lowest risk for congenital malformations, preeclampsia and preterm birth. During pre-pregnancy care, folic acid supplementation should be discussed and encouraged, and medications should be reviewed to ensure that there are no potentially teratogenic medications on board. Micro and macrovascular complications should be addressed and managed, and adequate education on expectations during pregnancy should be provided. Once pregnancy is confirmed, it's essential to maintain tight glucose targets throughout the pregnancy. This includes a fasting glucose of less than 95 milligrams per decilitre, a 1-hour postprandial of less than 140 or a 2-hour postprandial glucose of less than 120 milligrams per decilitre. There should be a focus on dietary optimization and physical activity in women with GDM and type 2 diabetes. And we discuss optimal pharmacotherapy choices, if needed, depending on whether the individual has GDM or type 2 diabetes. A final point is that diabetes care does not end with the pregnancy. Postpartum care is really important for women with type 2 diabetes to ensure that the condition remains tightly managed long term, and women with GDM require a postpartum glucose tolerance test and lifelong testing for diabetes every 1 to 3 years. Type 2 diabetes prevention strategies include lifestyle interventions, and metformin may have a particular benefit in preventing type 2 diabetes in women with a history of GDM and a diagnosis of prediabetes. We hope you enjoy reading this manuscript.
Next is Dr. Addie Cohen's chapter on bone metabolism, bone mass, bone structure during pregnancy and lactation, normal physiology and pregnancy, along with lactation-associated osteoporosis.
This is Addie Cohen, Professor of Medicine at Columbia University in the Division of Endocrinology and Director of the Early Onset Osteoporosis Center at Columbia, and I'm very happy to join this podcast. This year, in September of 2024, Endocrinology and Metabolism Clinics of North America has published an issue devoted to endocrine disorders during pregnancy. And I'm certainly grateful to have the opportunity to contribute to this wonderful special issue with a chapter entitled Bone Metabolism, Bone Mass, and Bone Structure During Pregnancy and Lactation, Normal Physiology, and Pregnancy and Lactation-Associated Osteoporosis. As reviewed in the chapter, normal pregnancy and lactation are states of high calcium demand due to fetal and infant calcium needs. Several processes, including hormonal changes, changes in calcium absorption and renal calcium handling, and skeletal demineralization, meet these needs during normal reproduction. These are expected and substantial changes in bone structure and bone mass during this time, with documented declines in bone density during pregnancy and lactation, followed by recovery during and after weaning. The progress and degree of the recovery appears to be site-specific, and there may in fact be lasting structural changes associated with reproductive events. However, available data suggests that we should not assume that lasting changes have a detrimental effect on skeletal integrity, since there are also studies suggesting that these changes may be adaptive, even possibly protective, in the context of future menopausal bone loss. In addition, many large studies have documented that pregnancy and lactation have no negative effect on fracture risk later in life. All of that, of course, applies to the situation of normal physiology. But there is another scenario. The rare situation of pregnancy and lactation-associated osteoporosis, sometimes abbreviated PLO, a term used to describe an early onset osteoporosis presentation with fragility fractures that occur in the context of the bone mass and metabolism changes associated with pregnancy and lactation. The majority of cases identified as PLO include vertebral fractures, but can include other types of fractures, including hip and pelvic fractures. This is often a severe osteoporosis presentation with 4 to 5 fractures on average, and symptom onset is usually during lactation rather than during pregnancy. Very low bone density by DEXA and volumetric and structural bone deficits have been documented. As with other presentations of early onset osteoporosis in adulthood, clinical evaluation in PLO should focus on a search for both primary and secondary etiologies of bone fragility. Some may have multiple potential etiologies or contributing factors for bone fragility, while other cases are really considered idiopathic after extensive evaluation. Management decisions depend on many factors, including disease severity, underlying etiologies, and future pregnancy plans. Some may choose observation of natural recovery with weaning, return of menses, and adequate calcium and vitamin D, and others may opt for medical therapy. Teriparatide is the most studied initial therapy for PLO and has been shown to augment postpartum BMD recovery. But we should keep in mind that there are no randomized controlled studies in this area, and the effects of treatment on fracture risk are not yet known. The chapter reviews the available data on management approaches as well as the many knowledge gaps in this area. And we're looking forward to all of the future research that will help us to learn more about underlying etiologies of this condition, as well as the research that will help us to optimize our management approaches for this particular type of early onset osteoporosis.
Next, we'll hear from Dr. Ellen Seeley, who co-authored the chapter Update on Preeclampsia and Hypertensive Disorders of Pregnancy with co-author Emily Rosenberg.
Hi, this is Ellen Seeley, and I'm from Brigham and Women's Hospital and Harvard Medical School. I want to tell you a little bit about the chapter you're going to be reading on Update on Preeclampsia and Hypertensive Disorders of Pregnancy. For so many years, there weren't any advances in this area, but more recently, several advances have occurred which can improve our management of patients. First, we discuss the use of low-dose aspirin initiated in the first trimester to reduce preterm preeclampsia in high-risk women. The aspirin does not reduce term preeclampsia, but does reduce preterm preeclampsia. In addition, we discuss the FDA approved the use of the ratio of soluble FMS-like tyrosine kinase 1 over placental growth factor for short-term prediction of preeclampsia. This test can be used when a clinician is ruling out preeclampsia, and it has very good negative predictive value of showing if the ratio is low that the patient has a low likelihood of developing preeclampsia in the next 2 weeks. This test can be very helpful in deciding which patients need to be admitted to the hospital and which can be observed at home, and can help dictate the type of monitoring an inpatient should receive. For many years, the blood pressure at which women with chronic hypertension were treated was very high at 160 over 110. Because of a recent study and confirmatory studies, organizations now recommend a threshold of 140 over 90 for initiation of blood pressure medications during pregnancy and as a goal, blood pressure. Finally, there's increasing data emerging supporting that although preeclampsia resolves with delivery of the pregnancy, that women who have had preeclampsia have increased cardiovascular disease risk, including mortality. As a result, all Paris women need to be asked whether they had pregnancy complications, and if the patient had prior preeclampsia, that counts as a major risk factor for heart disease, and the patient should receive risk reduction counseling, screening, and initiation of therapy if a risk factor is present. All in all, it's been great that there are more things we can do to help women with hypertension during pregnancy than we could a few decades earlier.
Our last chapter that we'll discuss today is written by Dr. Yasemin Madlodzega, and she will discuss the chapter on hypercalcemia associated with pregnancy and lactation, co-authored with Drs. John Belezikin and Deborah Selmeyer.
This is Yasemin Madlodzega, Clinical Assistant Professor of Endocrinology at Stanford University. In this article, we discuss hypercalcemia associated with pregnancy and lactation. During pregnancy, the diagnosis of primary hyperparathyroidism is established by elevated albumin-adjusted serum calcium or serum ionized calcium levels, along with increased or inappropriately normal parathyroid hormone levels. Differentiating between primary hyperparathyroidism and familial hypocalciuric hypercalcemia, or FHH, is essential to ensure timely intervention in primary hyperparathyroidism and also to avoid unnecessary surgery in cases of FHH. The calcium to creatinine clearance ratio may be unreliable during pregnancy. Therefore, if FHH is suspected, DNA analysis and/or testing for hypercalcemia in family members should be considered. Imaging modalities in primary hyperparathyroidism should be used with caution during pregnancy due to the risk of radiation exposure and should be reserved for guiding the surgical approach in patients scheduled for parathyroidectomy. Mild cases of primary hyperparathyroidism can be managed conservatively with supportive care. If conservative treatment is insufficient, parathyroidectomy is recommended during the second trimester. Medical options for managing hypercalcemia during pregnancy are limited, as there is very limited data on the safety of hypercalcemia medications in pregnancy.
For an exclusive discount on the issue we discussed today, focusing on updates on endocrine disorders during pregnancy, visit us.elsevierhealth.com/expert. Endocrinology and Metabolism Clinics is available for individual print subscription with accompanying online access, as well as individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter at Clinics Reviews and subscribe to the Clinics Review Articles podcast wherever you get your podcasts. Thanks for listening.